Addiction, drug of no choice. And this is from a 12-step perspective. Um, Oftentimes I think, primarily the treatment center industry has adopted the term drug of choice. And I did do some research to try to find out where that term came from and didn't find anything. But I do think it's interesting and always have found it interesting that uh, when it comes to addiction, the one drug that people usually have no choice over, people call their drug of choice. So, what I thought I would just cover today is primarily things that we hear that may not necessarily line up with what we know about addiction biologically, but also from a 12-step perspective. And one of the first things that I thought about, one of the things that we hear often is, or sometimes even say as clinicians, is that a patient, and by the way, as we're talking about addiction, we're talking about any kind of addiction, whether it be an eating disorder, self-harm, substance use disorder, any kind of addiction, gambling, things like that. One of the first things that we often hear, or maybe we even hear ourselves saying, is a person they haven't had enough consequences yet. And once they have, experienced a certain number of consequences, then they'll choose to stop using or choose to stop engaging in their behavior. And my experience in working with patients, and I think also what aligns most with the science and also the big book of AA, which is really the seminal text on addiction in terms of, if we're looking at things from a 12-step perspective. And one of the things that we see is that there really isn't any kind of consequence that can prevent somebody from engaging in their addiction. That I've seen people who have had 3 DUIs and they go right back to drinking, or I've seen people have massive reconstructive surgery on their nose from cocaine use, and they have the surgery, and the first thing that they do after they heal from their surgery is they return to use. Or somebody will have gastric bypass surgery, and the first thing that they do after they heal from the surgery is they return right to binging and sometimes purging as well. And so the question is, why would anybody choose to do this? And the answer is that they're not choosing, that the part of their brain that's responsible for executive function, the prefrontal cortex, in a person with addiction, that part of the brain is compromised. And so if we also look at, this idea that they can just choose not to drink, use, or act out, or what we hear a lot of times from patients is, I can stop if I want to. Or I relapsed because I changed my mind. And that's one that I hear a lot of times in sessions. And typically when I hear that in particular, I just changed my mind. What I'll ask a patient is, did you change your mind, or did your mind change you? Because there is a flip that happens in the mind of somebody with addiction that occurs, and it isn't really that they're changing their mind. It's that their mind is changing them. And this idea that I can stop if I want to, that may be true for a certain period of time. The question is, can they stay stopped? And so I've just pulled some quotes from the big book of AA that we can apply to any addiction. And this first quote here is really addresses everything that I've just been saying here. So the quote is, "The fact is that most alcoholics, for reasons yet obscure, have lost the power of choice in drink. Our so-called willpower becomes practically non-existent. We are unable at certain times to bring into our consciousness with sufficient force the memory of the suffering and humiliation of even a week or a month ago, we are without defense against the first drink. So they're not talking about somebody having already started to drink or having started to use or having started to binge or having started to restrict or whatever it is. They're talking about the condition that hopefully all of us are in right now, which is sober. That the most insane thing that somebody with an addiction will do is to pick up or to relapse from a state of consciousness that is called sobriety. The other one that I like to challenge is this idea of calling somebody before you use. And I think that while, there's good intentions behind that, I think sometimes that in the interest of compassion, and all of us as clinicians want to have compassion for our patients, that sometimes in the interest of compassion, that truth sometimes suffers. And though the idea of calling somebody before somebody uses sounds good, it's not really consistent with science, because what we know is that a relapse ends when somebody picks up. And so by the time they're getting ready to pick up or act out, it's already too late. That what we really want to look at is, okay, what was going on in the days and weeks before? Were you working with a sponsor? Were you going to meetings? Where were you in the steps? And the quote that I've pulled here from a big book is, this is from a chapter called More About Alcoholism, and it's at the end of step 1. Step 1 is we admitted we were powerless over whatever their drug of no choice is, dash that our lives had become unmanageable. And the quote here is, once more, the alcoholic at certain times has no effective mental defense against the first drink. Except in a few rare cases, neither he nor any other human being can provide such defense. His defense must come from a higher power. And so I just want to say, forgive the sexist language. This was before they knew better. And I think, if this was written today, we would probably be using, other pronouns. But the message behind it here is that an alcoholic or an addict or somebody with who's afflicted with any kind of addiction can get taken to a place where they have no mental defense against that first drink or the first drug. And that sometimes a person with addiction could get taken to a place where there's actually no thought about using at all. And they just sort of find themselves in the middle of a binge. And there was no effective thought or premeditation before using or acting out. Another one of the things that we hear a lot is that AA is religious, and because of that reason, it won't work for me. And, it's one of those things that we hear very frequently, and I think we as clinicians have to work really hard to talk about what the difference is between religion and spirituality. But sometimes even the word spirituality is hard for somebody to hear, because a lot of our patients come into treatment with a lot of trauma, religious trauma, spiritual trauma. And so the focus that I think we want to place is on not necessarily spirituality or even religion sometimes, but having an open mind. And so the quote that I've pulled from the big book here is, and this is from the appendix on spiritual experiences, most emphatically, we wish to say that any alcoholic capable of honestly facing his problems in the light of our experience can recover, provided he does not close his mind to all spiritual concepts. He can only be defeated by an attitude of intolerance or belligerent denial. We find that no one need have difficulty with the spirituality of the program. Willingness, honesty, and open-mindedness are the essentials of recovery, but these are indispensable. And, this really points out, I think, willingness, honesty, and open-mindedness are often the things that a newly sober person, or a person who's just coming to treatment for the first time, or just coming into recovery for the first time, um, may not have any of these things other than the willingness to show up. And so, I think it's important to keep that in mind, that no matter where somebody is, we can meet them where they're at. And just underneath this, what the book says is, there's a principle which is a bar against all information, which is proof against all arguments, and which cannot fail to keep a man or person in everlasting ignorance. That principle is contempt prior to investigation. And I'll talk about that a little bit more in a few slides here. So another one of the things that we hear a lot is, I only use, drink, or binge, or restrict, or self-harm on the weekends. And so when somebody talks about that, it's very hard for them to see sometimes the severity of their disease. And so usually with somebody like this, what I try to ask them is, okay, so you only binge on the weekends. Sometimes you binge, sometimes you don't. My question for you is, are you in charge of the times you do and the times that you don't? If you aren't in charge of the times that you do, and you aren't in charge of the times that you don't, it doesn't really matter that you're a binge user, because it's just happening beyond your mental control. Another element that I think is important to look at is when we hear from a patient, I don't use that much. That when I use, it isn't that much. And the thing that I would challenge with that is intent. And the question here is, when you set out to use or to engage in a behavior and you have an intent, does it go the other way? And that's where we want to look at three words that are synonymous: power, choice, and control. If I've lost one of those things, I've lost all three. In other words, I can't be powerless over drugs and have a choice. That those two thoughts don't really go together. And so I can't be powerless over something and have the ability to necessarily call somebody always. Another idea that I think is really relevant to our work as clinicians who treat complex co-occurring disorders is that this idea of, I only use to self-medicate my trauma or my depression or my anxiety. And we can very easily forget that addiction is primary and can have a life of its own. And so while it's true that most of us have never met somebody who struggles with addiction who doesn't have trauma, that if the addiction isn't treated, there's really no hope of treating that trauma. And also, addiction, as I said, can really take on a life of its own. And it's comprised of three things: a mental obsession, which means when I'm not engaged in my addiction, my mind takes me to the addiction, whether I want to or not. So the idea here is, yes, I use when I want to, but also I use when I don't want to. And sometimes I use when I'm not thinking about using at all. Then there's also a physical craving, or the big book calls it an allergy. So in treatment language, a lot of people use the word craving. Did you have a craving today? In 12-step language, a craving can only happen after you've started to ingest alcohol, or after you've already started to engage in whatever the behavior is. Something gets activated, and we don't have any control over the amount that we take. And then the third piece is a spiritual malady. And that's what a lot of people describe as feeling like, I never felt like I fit in, or I've always felt like there was something wrong with me, or I always felt like everyone else got the manual to life and somehow I missed that day. And that really is the unmanageability that we talk about in the first step is the same thing as the spiritual malady. That the unmanageability of a patient's life isn't just all the crazy things that they do when they're engaged in their addiction, more the maladaptive behaviors. It's how they feel right now, which the big book describes as restless, irritable, and discontent. So I want to dispel this myth that somebody has to uh, use a lot, that the quantity is important, or that they have to have been engaged in an addiction for years. And this quote I've pulled here is from page 34 in the big book. To be gravely affected, one does not necessarily have to drink a long time, nor take the quantities some of us have. Certain drinkers who would be greatly insulted if called alcoholics are astonished at their inability to stop, or I would say to stay stopped. We who are familiar with the symptoms see large numbers of potential alcoholics among young people everywhere. So the word potential is another important piece for us to look out for, because somebody who is just at the very beginning of the progression of their disease, where it isn't full blown, it may be harder to spot. And so it's important as clinicians that we're looking for the red flags. So I've just pulled, speaking of red flags, I've sort of distilled down 3 attitudes that we can look for as clinicians when it comes to the 12 steps and addiction. An attitude, the word attitude, if you think about what it means in terms of an angle of approach, like when an airplane is coming in for a landing, the pilot will ask, or the control tower will ask the pilot, what's your attitude? In other words, what angle are you coming in at? And so when we're working with a patient, we want to look at what is their attitude. And there's 3 main attitudes that I think that we see. And the first attitude is the attitude of the bigot, which is somebody who is stuck in this place of obstinacy or sort of unreasonably attached to a belief or opinion. And what that person is blocked by is contempt prior to investigation. The second attitude that we sometimes see is an attitude of a pious person. And what this person is, surprisingly enough, blocked by is acceptance. They just believe anything that anybody tells them, including their peers. Let's say a peer says something like, I tried AA, it doesn't work, so I'm doing smart recovery. And that person picks up on it and they don't investigate the recommendation of their therapist who's recommending 12 steps first. And they're kind of like the person sitting between members of 2 different political parties. And when they're talking to a Democrat, they're a Democrat. And when they're talking to a Republican, they're a Republican. Not to bring politics into it, but it's just we pick up on something somebody else says and we just run with it without taking it inside and actually having our own experience. And the last attitude is the attitude that I think we eventually want to arrive at, and that's being the person of consideration, that I'm willing to consider all different sides of an argument or a question. If I'm asking the question, am I alcoholic? Well, maybe I am, and maybe I'm not. And when I'm willing to look at both sides of a question, it places me in the middle where the truth is. So as we start to meet with our patients, we want to look at, what kind of attitude does this person have? Because that will inform our clinical decisions in terms of how we want to intervene. So we're coming to the end here, and I just want to talk about what it means to be fully engaged in a 12-step program and what it means to be fully involved in recovery. Here you see what 12-step programs call the circle and the triangle. This is primarily AA uses this, but it's still an important piece of information. I think that in order to be fully immersed in recovery, that we need to be involved in sponsorship, and that's somebody who takes you through the steps. That we want to be involved in a home group, and that means I'm going to the same group every week, and people would notice if I wasn't there. And also that I'm involved in all three sides of this triangle that you see here. Recovery is the mind. We need a new mind. Fellowship is where we take our body. And to be of service is to be engaged in acts of spiritual service. And so a lot of times when people first engage in recovery, they've brought their body to the fellowship, but they have a mind that takes them back to their addiction. So you see unity there. People are going to meetings, but their mind keeps taking them back to a drink or a drug or back to their drug of no choice. And so they need a new mind, and that's what they find in recovery through the steps. And then you bring that awakened mind or awakened spirit back into the fellowship and out into the world to be of service, and that's the meaning of the circle, that one day we can become whole. Why try 12 steps first? Because there are a lot of other programs, and it isn't that any of them are bad. It's just, when we look at a lot of the studies, particularly this most recent study that I found, is Stanford University study from 2020, found that AA, 12-step programs, 12-step facilitation reduced mental health costs by $10,000 a person. And that same study found that AA or 12-step facilitation was 60% more effective than cognitive-based approaches like DBT or CBT for addiction. And that study was comprised of over 10,000 people. And that isn't to say that DBT or CBT are bad. What the study found, though, is that when it comes to addiction, that 12-step facilitation is 60% more effective. Lastly, I just wanted to mention some myths that are busted by the Big Book. And if you're interested, I can send you a copy of this presentation, and you can look up these pages. First, that it's religious, that even though the word God is used in 12 steps, that it really is roomy, and you get to pick any kind of higher power that works for you, including if it's just a group. The idea that members are forced to stay in a position of powerlessness, powerlessness is only mentioned once, and it's in the first step. And the paradox of step one is that if I can concede that I have no power, that I receive more than I've ever been given, that I'm actually given the ability to make choices in my own life, that members can't trust themselves is another myth, that we do get taken to a place through the recovery process where we can start to trust our own mind, where we can have access to our intuition, which can help us then heal from our own trauma. Also, that members are discouraged from having therapists, doctors, and other sources of support, and that members are discouraged from taking medications. The Big Book is pretty clear, if you go to page 133, that if you need outside support, that it's really important that you get that, including medication-assisted therapies. So that's it. I'm going to stop sharing my screen here and check in with everybody and see if anybody has any questions.
Hey, Shale, really nice job. That was really excellent. I think I just wanted to add that I know a lot of times, much more than in the past than now, there were a lot of AA meetings where there was a lot of thought about not being on meds, and sponsors were telling patients not to take psych meds. But I think that's pretty much lifted, from my understanding of the people I work with, but that's an old wise, an old reality.
Yeah, I think that it still does happen sometimes.
Right.
And, I think that a good thing to remember for us to tell our patients, and what I've always heard in recovery is that if you can't reconcile what somebody says with the actual literature, then you can disregard it. And that message that if you're on medications, you're not sober is not consistent with any of the literature in any 12-step program. So thanks for bringing that in. Anybody else have any questions or comments? I know we're just about out of time.
Thank you, Shale. That was great.
Thanks, Shell.
Yeah,
Thanks.
thank you. Very good. Very nice.
Well versed on the big book. Thank you.
My pleasure.
I think all the patients would really benefit from, you know, seeing this. I think that would be really powerful if we had it be where it was like something for all the patients too.
I was
That's a
thinking
great
that same
idea.
thing.
Yeah.
This would be really good for our patients to see.
100%.